and we want her to cover the entire spectrum. So thank you, Smiley, for accepting the invitation to cover this up. Dr. Smiley has done fellowship in neuroradiology from AIMS Jaipur, fellowship in cardiovascular and thoracic radiology also from AIMS Jodhpur. She is right now assistant professor at Sri Chitra Trinal Institute for Medical Sciences and Technology, Kerala, India. Her primary areas of interest are neuroradiology, pediatric neuroradiology, and cardiac imaging, and she has 26 publications to her account. So, thank you, Smiley, once again, and the session is over to you. And I know it's going to be an amazing one like the last one.
Thank you so much, ma'am, for the kind introduction. I look forward to this session as well. And thank you very much for everyone for joining. So now we'll be continuing from our previous session. In the previous session, we discussed about the demyelinating leukodystrophies. And today we'll be discussing predominantly hypomyelinating leukodystrophies. So before starting, I'll just give a brief outline. So we'll discuss about normal myelination. We'll first discuss about some concepts about hypomyelinating leukodystrophies, and then we'll look at the cases, and in the end, we'll have a small revision. So before starting, I want to disclose that most of the images and tables taken in this presentation are from a recently published article in the Journal of Magnetic Resonance Imaging. So hypomyelinating leukodystrophies are clinically and genetically heterogeneous diseases characterized by a permanent deficiency of myelin deposition in the brain. Now, what happens is these children, they have a global developmental delay, they present with psychomotor regression, and they have a considerable clinical overlap. So in such a scenario, we are requested to have an MRI of the child, and it is the MRI which points towards the diagnosis of hypomyelination, of course, on the background of features like spasticity, nystagmus. And MRI provides a clue towards the diagnosis and helps in guiding towards the genetics, which provides the final diagnosis. So as we discussed last time, just a very brief introduction about normal myelination. So myelin is composed along with water. The dry mass of the myelin is comprised of 70% of fat and 30% of proteins. So because of predominance of the fat, so whenever the myelin is deposited, the normal myelin leads to reduction of both T1 and T2 relaxation times. Therefore, normal myelin will appear as hyperintense on T1 and hypointense on T2 relative to the gray matter. But the rates at which this occurs, this reduction of T1 and T2 is different. T1 shortening by myelination happens earlier and quicker, whereas T2 shortening is a more gradual process. So, as we all know, that T1 weighted sequence is used to assess myelination in the first 6 to 8 months of life, and T2 weighted sequence is used to assess myelination beyond that. So according to fundamental law of myelogenesis, normal myelination occurs in a very precisely organized temporal and spatial manner. So it occurs from central to peripheral, caudal to cranial, and rostral to ventral manner. As we saw this image in the last presentation as well. So there is a famous myelination clock which can guide us, like which structures myelinate at what times, but we should at least know the earliest myelinating structures, which are the dorsal brainstem and posterior limb of internal capsule and periodontic white matter. These are the structures which should be myelinated at birth in a term child. And as we see, the T1 weighted image will appear, normal myelin will appear hyperintense, and they will appear as hypointense on T2 weighted image. So again, we saw this image in the last session. So like previously, we can have the chat and you all can tell that the first image is what and the second image is what. Basically, differentiation between the hypomyelination and demyelinating leukodystrophies. So the first image is the chat. Please enter in the chat. Yes, I can see the chat. So the first image is, we're able to see mildly hyperintense signal of the white matter, whereas on T1 weighted, yes, the first one is hypomyelinating and the second one is demyelinating. So as we discussed last time, So how to recognize hypomyelination on MR is that we see that there is abnormal hyperintense signal of the white matter on T2 weighted image. However, this abnormal signal is just mildly hyperintense, whereas in demyelinating leukodystrophies, the signal of the white matter is more conspicuously hyperintense on T2 weighted image, and on T1 weighted image in demyelinating leukodystrophies we'll have a hypointense signal, whereas in hypomyelinating leukodystrophies it may be hyper, hypo or iso depending upon the amount of myelin deposited. So whenever we are labeling any patient with hypomyelination, so it is very important that whenever a child comes for MRI for the first time, so if the scan is done at less than 1 year of age, we should not directly label it as hypomyelination. We should rather tell that it is delayed myelination for age. And it is important that if the first scan is done at less than 1 year of age, there should be a follow-up scan after at least 6 months, and the second scan should be after 1 year of age to determine whether there is same pattern of deficient myelination on the second scan as well. If there is the same pattern of deficient myelination, deficient myelin deposition, then we term it as hypomyelinating leukodystrophy. However, whenever, as in the second case, we see that when the child was small, the on MRI, it was appearing to have hyperintensities. However, when we followed up, it was showing a normal myelin pattern. So these are cases of delayed myelination. So rather than directly labeling the patients as hypomyelinating, we should first label them as delayed myelination, and we should request for a follow-up scan at least 6 months apart, and the second scan should be at an age greater than 1 year, so as to determine whether it is hypomyelination or delayed myelination. And in fact, delayed myelination has a lot of treatable causes. For example, deficiencies of vitamins, vitamin B12, iron, folate deficiency, congenital as well as acquired, as well as delayed myelination if associated with congenital hypothyroidism. So there is one MCT8 mutation and Allen-Hurdle-Dudley syndrome, which you can remember, and there can be other pathogenic variants as well. However, certain authors suggest that if the scan is done at a higher age, for example, the patient is first time only scanned at around 4 to 5 years of age, more than 2 years of age, and still there is definite hypomyelination, so there is no need to repeat the scan because it is unlikely that after 2 years the patient will have just delayed myelination. So the genetic and pathophysiologic basis of hypomyelinating leukodystrophies are that we all know that myelin sheath is deposited by the oligodendrocyte, but it is a very energy consuming and very systematic process which not only involves the oligodendrocytes, but there are a lot of interactions between the oligodendrocytes with the astrocytes, as well as there are growth factors involved. There are gap junctions, there should be proper functioning of the gap junctions. So any of these factors, if abnormal, can lead to hypomyelinating leukodystrophies. So there are not only disorders secondary to disorders in myelin structure, but also because of the cytoskeletal proteins of oligodendrocytes, because of abnormal gap junctions, because of abnormal translation and transcription machinery, because of abnormal growth factors, as well as any DNA nucleotide repair defects, as well as there is another component of hypomyelinating leukodystrophies, which are different from the primary deficiency of myelin. These are secondary hypomyelinating leukodystrophies. Basically, these are neurodegenerative disorders, and in this, the hypomyelination is secondary to the secondary deficiency of myelin rather than primary deficiency of the myelin. So, depending upon the clinical features and depending on the pathogenesis, hypomyelinating leukodystrophies can be divided into primary hypomyelinating leukodystrophies and secondary hypomyelinating leukodystrophies. As we discussed in the previous slide, there can be primary disorders where myelin deposition is affected, and these patients have the typical prototype of hypomyelinating leukodystrophies. They present with psychomotor regression. They have a global developmental delay with nystagmus, spasticity, ataxia. But the cognition is usually preserved in these patients, and they have a good visual contact. Whereas the secondary hypomyelinating leukodystrophies, these patients are more severe. They have severe global developmental delay. They often have epilepsy and can present with epileptic encephalopathy, and they have poor visual contact. These are basically neurodegenerative disorders. So when we do MRI, even at an earlier age, they will have a lot of neurodegenerative features with marked atrophy of the parenchyma. Whereas in primary hypomyelinating leukodystrophies, there may be atrophy of the parenchyma, but it usually occurs later in the course of disease. And initial MRI may not show as much as atrophy as in older patients. And apart from the MR features, there are certain specific clinical features, like apart from the normal clinical features of hypomyelinating leukodystrophies, for example, nystagmus ataxia, there are certain specific clinical features which are clue to hypomyelinating leukodystrophies, and we'll discuss each of them as we see the cases. So, whenever a patient of hypomyelinating leukodystrophy comes, whenever we are discussing the MR features, we should always be aware of the clinical features. For example, there will be certain specific clinical features which will be actually a great clue to the diagnosis. For example, if the patient is having hypodontia and hypogonadotropic hypogonadism, it can be associated with polar 3 related leukodystrophies. So there are certain specific clinical features which in conjunction with the MR features can help us guide towards the pattern of hypomyelinating leukodystrophy. Then whenever we are doing MR, so the most important sequences for hypomyelinating leukodystrophies again remain T1 and T2 weighted image, because these primarily are very small children. Up to 2 years of age, we do not rely on flare because of incomplete suppression of water. So we use T1 and T2 weighted images as the principal sequence. Apart from that, SWI is useful to detect mineralization and calcifications, but sometimes even SWI may not show calcifications, and a non-contrast CT brain may be required if we are specifically suspecting calcification in certain disorders like Cockayne syndrome. Apart from that, certain clinical features, if the patient is having sensorineural hearing loss, we may need to add 3D heavy T2 weighted image to look for any inner ear anomalies. And we can also use MRS in certain conditions when we are suspecting, for example, Sal's disease or fucocytosis. These can be helpful in certain specific disorders, not all, but whenever we are evaluating a case of leukodystrophy, it is better to include MRS because MRS can provide clue in many cases. Then there are advanced MR sequences which are not used clinically but are mainly for research purposes, but they are very useful for providing quantification of myelin. So there are different sequences which can be used for myelin quantification. That there can be myelin water fraction, magnetic transfer imaging, diffusion tensor imaging, G ratio. We're not discussing all of them, but just I'm telling you the names that these can be used for myelin quantification. And one more sequence which can be actually useful for clinical purpose as well, and can provide myelin quantification. It just requires a post-processing of 1 minute, and it will provide the color-coded myelin maps, is synthetic MR. Now, the problem with this is that it is not widely available. Now, we have in our institute, it is on research, it is for research purposes. So for now, it is still in research purpose, but it has, like in future, it has a potential to be used clinically because it provides myelin quantification, provide color-coded myelin maps, as well as it provides the contrast-weighted images like T1, T2, which can be used clinically as well. So this was just a brief discussion about hypomyelinating leukodystrophies before we start discussing the MR features and have a pattern-based approach. So whenever we are dealing with the case of leukodystrophy, so we have to decide, as we saw earlier, as we had our rules, that we have to look at the age, we have to look whether it is normal myelination or not, we have to look whether it is hypomyelinating, demyelinating, then we have to look for certain specific features and patterns. So in hypomyelinating leukodystrophy also, by using a pattern-based approach along with clinical clues, we can reach towards like certain specific patterns of hypomyelinating leukodystrophies as well. So there are different patterns. So we consider this as a T2 weighted image where we are seeing that there is hypointense signal of the white matter, uh, and this is the first pattern in which we see the hyperintense signal of the entire white matter. So this pattern is diffuse hypomyelination. So apart from this diffuse hypomyelination, the other pattern can be when there is diffuse hypomyelination, but there is sparing of certain white matter structures. Then the other patterns can be when there is diffuse hypomyelination, but instead of sparing of certain structures, there may be just involvement of certain structures more conspicuously. For example, in this case, periventricular white matter is more conspicuously involved in addition to diffuse hypomyelination, whereas in this case, only certain specific structures are involved by hypomyelination. Then apart from the pattern of white matter involvement, we can have a classification based upon what other organs, what other brain structures are involved. For example, there can be hypomyelination with cerebellar atrophy, there can be hypomyelination with brainstem involvement, and there can be hypomyelination with T2 hypointense thalamus. Also, in addition, like previously we studied that whenever there is T2 hypointense thalami, we should always consider lysosomal storage disorders in our mind. And here also the same pattern follows that certain hypomyelitic leukodystrophies, which are secondary hypomyelitic leukodystrophies and are lysosomal storage disorders or any storage disorders, they can have T2 hypointense thalami. Apart from that, there can be basal ganglia pattern based on the basal ganglia involvement, which we'll study, and then there can be hypomyelination with calcifications. So there are various disorders which fall under each of these patterns, and we'll discuss each of them with the cases. So now we had a brief discussion of what is basically hypomyelintic leukodystrophies, what are the clinical features, the pathophysiologies, and MR-based pattern approach. Now we look at each of this approach by seeing few cases. So whenever we have a case, we have to identify hypomyelination. We'll give a broad MR classification, whether it is diffuse hypomyelination or hypomyelination with sparing of certain specific structures. We'll look at certain specific additional clinical feature or certain specific MR feature, and we should obviously know any other salient points of that disease. So beginning with the first pattern, that is diffuse hypomyelination. So this is a case for you all. So this is a boy and who is having nystagmus spasticity. So what are your thoughts about it? You can write in the chat. So what do you think is this case? It is a hypomyelitic leukodystrophy. So what do you think? So what, any hypomyelitic leukodystrophy which you feel, which you know of, and which you think it can be? So what is the prototype hypomyelitic leukodystrophy? Yes, very good. So it is diffuse hypomyelination. It is Palacios-Merzbacher disease. So this is the prototype hypomyelitic leukodystrophy. Yes, there is cerebellar atrophy, but here the predominant feature is not cerebellar atrophy. It is not out of proportion of the hypomyelination. So here we are seeing that there is diffuse, mildly hyperintense signal of the entire white matter, including internal capsules, including periventricular subcortical white matter. And what we see in the brainstem is that there is involvement of the white matter of the brainstem as well, but there is pairing of the ventral brainstem white matter, like the ventral pons is paired except for the corticospinal tract. So Palacios-Merzbacher disease is a prototype hypomyelitic leukodystrophy. It is usually X-linked recessive and caused due to pathogenic mutations in the proteolipid protein, that is the primary structural protein of the myelin. So in this, what happens is we have diffuse hypomyelination, and one feature which you can remember to differentiate it from another leukodystrophy, which is very similar to it, is that in the brainstem, the ventral brainstem is spared except for the corticospinal tract. There can be associated corpus callosal atrophy, which is not seen in this case. However, there can be associated, and especially if the patient has progressed to a later stage, and there can be associated cerebellar atrophy as well. So we'll just see case 2 and then we'll compare both the features. So this is another case of a girl. Previous was a boy because it was an X-linked recessive case. Although it can be seen in certain like there are certain phenotypes of Pelizaeus-Merzbacher disease which are very severe, which are congenital forms which can involve females as well, but more commonly Pelizaeus-Merzbacher disease is seen in males. So we have second case, which is a female, which had similar features. And here we are seeing almost similar MR features, except for one feature, which may provide a little bit differentiation, like if we are able to catch it up, especially for your spotters. But in routine practice, obviously, we'll give both the DB. So what do you think about what is this case? The previous was Pelizaeus-Merzbacher disease. Now again we see diffuse hypomyelination, but here we see in addition to the dorsal brainstem, the ventral pons as well is involved, as well as there is involvement of the middle cerebellar peduncle. There is associated corpus callosal and cerebellar atrophy. So what are your thoughts about this case? Yes, very good. So it is Pelizaeus-Merzbacher-like disease. So it is very difficult to differentiate the two. But whenever we are getting diffuse hypomyelination, we can give both as TTs. But when we are seeing that ventral brainstem is also involved, so we should prefer Pelizaeus-Merzbacher-like disease over Pelizaeus-Merzbacher disease. And clinically, they are different. Clinically, Pelizaeus-Merzbacher-like disease is seen more commonly in females, and like it can be seen in males as well as females, but Pelizaeus-Merzbacher disease is seen more commonly in males because it is X-linked recessive, whereas this is autosomal recessive, so it can be seen in both. And it is clinically much less severe than Pelizaeus-Merzbacher disease. The most common mutation associated with this JGC2, and it affects the gap junction proteins rather than primary proteins, the primary myelin structure. So in this case, other clinical feature which can be present is these patients can have additional peripheral neuropathy, and on MR, in addition to diffuse hypomyelination, we see both the ventral as well as dorsal brainstem involvement. So this is case 3, which is again a diffuse hypomyelination pattern, but here MR, I'm sorry, the arrow is little up here. It should be pointing towards this tall NA-like peak. So we discussed the causes of tall NA-like peak in the last lecture. So this is one of its cause. And at that time, yes, brilliant. So it is Sala's disease. So here what we see is there is diffuse hypomyelination. But one very specific feature is that almost always there is very much, like very significant corpus callosal atrophy. The cerebellum is relatively preserved as compared to the corpus callosum. And in addition to diffuse hypomyelination, we see a tall NA-like peak. And these patients usually they're not, it is a very not a very common disease. There are certain specific populations, for example, Finnish population, in which it is seen more. And it is a lysosomal storage disease and a secondary hypomyelinating leukodystrophy. So these patients, because it is a storage disorder, will have host faces, and we saw that the specific features are tall NA-like peak and corpus callosal atrophy. So to complete the diffuse hypomyelination pattern, I just want to tell you that there is another pattern which is not that common, but whenever we are getting a patient with Hirschsprung disease, patient is having peripheral neuropathy, Waardenburg syndrome, and along with that on brain, we see hypomyelination. So this is the case of SOX10 associated PCWH syndrome. And in this, what do we see in addition to hypomyelination? There can be associated inner ear anomalies. So whenever we are getting a case of hypomyelination with Hirschsprung disease, always try to include a 3D heavily detubated sequence in your protocol so as to rule out any inner ear anomalies. So this is the source image, and here we see in addition to the hypomyelination, there is also absence of the olfactory bulbs, and there is presence of semicircular canal dysplasia, which is a little widened as compared to the normal appearance. So the first pattern was diffuse hypomyelination. Now the second pattern is this case. So what are your views on this case? So this is a child. I'll just give a clue before that if you can crack this case. So we are seeing diffuse hypomyelination, but there is sparing of certain structures. So if you don't remember anything in hypomyelinating leukodystrophies, remember Palazius-Merzbacher disease, remember Palazius-Merzbacher-like disease, and remember this disease, like which can be a spotter and which can be a little common as well when we are dealing with hypomyelinating leukodystrophies. So we are seeing diffuse hypomyelination. In addition, there is sparing of certain structures. So what do you think is this structure? So this is not HEMS because we are seeing diffuse hypomyelination, not only the posterior brainstem involvement, but we are seeing diffuse involvement, but there is sparing of certain structures. HEMS rather involves only the early myelinating structures. Maybe seeing the dorsal brainstem, you thought of that. But what else it can be? There is sparing of this structure, which is optic radiation. So there is also sparing of the pyramidal tract of the internal capsule. Apart from that, there is sparing of the median lemniscus, and there is associated globus pallidus hypointensity, hypointense thalami, and there is corpus callosal atrophy. In this pattern, the clinical clue is that, so this image is not mine, taken from one of a very nice articles. So this patient has hypodontia and also has hypogonadotropic hypogonadism. So hypodontia, hypogonadotropic hypogonadism with hypomyelination. Yes, brilliant. So it is 4H syndrome. So this is polar 3 related leukodystrophy. So there can be pathogenic variants in the genes encoding RNA polymerase 3. It can be polar 3A, polar 3B, as well as polar 1C. In this case, it was polar 1C. So what do we see on MR? You have to remember is we see diffuse hypomyelination. But first of all, the clinical clue, if we get, then whenever we are thinking in terms of hypomyelination with those clinical clues, we are more likely to be sure that is polar 3 related leukodystrophy, that the clinical clues of hypodontia and hypogonadotropic hypogonadism. However, these clinical features may not always be present, and the MR features also may not always be present, but when they are present, then we can be more specific for the diagnosis. So in this case, apart from diffuse hypomyelination, there is sparing of the optic radiation, pyramidal tract of the internal posterior limb of internal capsule, and medial lemniscus. And there may or may not be, but usually it is associated with globus pallidus hypointensity as well. So the broad classification is hypomyelination with selective white matter sparing, and there can be different clinical features, but when we get 4H syndrome, then we can be sure of the diagnosis, and usually it is accompanied by corpus callosal and also cerebellar atrophy. And apart from this broad classification, even the subunits like can have different features. There's no need to so much remember, but just for telling you that polar 3A, if it is involved, then it is corpus callosal atrophy is predominant, polar 3B, cerebellar atrophy is predominant, and polar 1C, due to hypointensity of the substantia nigra and subthalamic nuclei are more prominent. So coming to the third, so this was the second pattern in which there was hypomyelination with selective sparing of the certain structures as we saw. Then we have another pattern when there is just selective involvement. So any guesses for this case? So what do we see? We do not see diffuse hypomyelination, but we are seeing hypomyelination only in certain structures. So there is hypomyelination. So there are white matter hyperintensities involving the pericentral white matter. There is hypomyelination involving the optic radiations, as well as there is hypomyelination involving the dorsal brainstem. So what are your guesses about this? So what are these actually? This posterior limb of internal capsule, periatlantic white matter, and posterior dorsal brainstem. When do these structures myelinate? We already discussed. So these are early or late myelinating structures. These are early myelinating structures as we discussed. So then any guesses? So in this, there is hypomyelination only involving the early myelinating structures. So this is a case of, it's not HELM, it is HEMS. So this is a case of hypomyelination of early myelinating structures. So in this also, like apart from these features that there is hypomyelination only involving the early myelinating structures, one specific pattern which can be seen in posterior limb of internal capsule is a trilaminar pattern. So in this, there are alternating hyper, hypo, and hyperintensities, so which gives a trilaminar appearance to the posterior limb of internal capsule, which is one of the features which can be seen in HEMS and can provide a clue towards the diagnosis. Now, this is another case which is taken from literature where we are seeing that the patient has cataract, and apart from diffuse hypomyelination, there is more conspicuous involvement of the periventricular white matter. So, this is a pattern which is seen in hypomyelination with congenital cataract. So, in addition to congenital cataracts, these children again have peripheral neuropathy as well. So what pattern we have to remember in this is that there is diffuse hypomyelination. In addition, there can be more conspicuous T2 hyperintensities involving the periventricular white matter. I know these are not very common cases, but we have to complete the spectrum, and these can come as spotters rarely in your exam. So today we are discussing these cases. Like previously you were very active and you were telling all the diagnosis, but it may be difficult for to pick up these diagnoses because they all look the same. But if we know these patterns, so this can distinguish us from the others and can help us reach towards a specific diagnosis as well as guide genetic analysis. So now we are coming to the next pattern, that is hypomyelination with basal ganglia involvement. So this is first case. This is a case which can come routinely as well. So this is a common diagnosis specifically with relation to hypomyelinating leukodystrophies. So I'll tell you the findings and then you can guess the diagnosis. So in this we have diffuse hypomyelination, and what we see is that the corpus callosum is typically preserved. So we are seeing that the signal of corpus callosum is preserved and the basal ganglia is hyperintense. So we have hypomyelination with basal ganglia involvement in the form of hyperintensity. There is in addition presence of T2 hypointense thalami on the ventrolateral aspects as can be seen in storage disorders. So any guesses? So there is a clinical feature which provides a great clue for this case. But seeing the MR pattern, any guesses you have? So which hypomyelinating leukodystrophy? We are seeing T2 hypointense thalami on the ventrolateral aspect. So what do you think? It is storage. Can it be a storage disorder? It is a storage disorder. So what do you think? With basal ganglia hyperintensity, hypomyelination, preserved corpus callosum, it is a storage disorder with cherry red spot at the macula. So what do you think about the diagnosis? Yes, Tay-Sachs, GM1, GM2, gangliosidosis. So what you have to remember in this is that in GM1, GM2 gangliosidosis, we are able to see this pattern. This is not a very rare diagnosis. So this is a common diagnosis, especially if we have the clinical clues with us. For example, cherry red spot in macula. Patient is a case of storage disorder. So we'll have hepatosplenomegaly and nephromegaly. But these patients, when it is an infantile onset GM1, GM2 gangliosidosis, usually the appearance will be like that. When it is late onset GM1, GM2 gangliosidosis, then these changes may not be seen and the white matter may be normal. So the hypomyelinating leukodystrophy in case of GM1, GM2 gangliosidosis is in case of infantile onset types. And what we see here is that we see is diffuse hypomyelination. Apart from that, we have to remember is that there is presence of hyperintense basal ganglia. And the corpus callosum is almost always preserved. So this feature you should remember. So apart from in today's lecture, what we should remember is PMD, PMLD, Polar 3, and then this pattern. So at least these 4 patterns should be with you when you end up listening this lecture. So then there is another pattern in which there is diffuse hypomyelination, and then what do you see? So this is basal ganglia, and what peculiar feature you see in the basal ganglia? That will actually clinch the diagnosis. These patients usually present with dystonias apart from the features of hypomyelinating leukodystrophies. And the dystonias are more predominant as compared to the other features of hypomyelinating leukodystrophies in these patients. Apart from this structure, there is also something here. So there is cerebellar atrophy. So in addition to cerebellar atrophy, what do we see in the basal ganglia? Do you see any signal changes or any volume loss? So there is very significant atrophy of the basal ganglia. Yes, very good. So there is a significant atrophy of the basal ganglia, and in later stages, it may appear that the putamina, especially the putamina involved, and the putamina may be maybe looking as disappearing basal ganglia. So there is significant atrophy of basal ganglia and cerebellum, and this basal ganglia atrophy is out of proportion to the hypomyelination. So there is hypomyelination, but there is very predominant basal ganglia and cerebellar atrophy. So from as the name suggests, the can you guess the diagnosis? There is hypomyelination with atrophy of basal ganglia and cerebellum. It is actually HABC. The name itself is hypomyelination with atrophy of basal ganglia and cerebellum. So these are caused due to tubulin beta 4A gene most commonly. So we know about tubulinopathies. Tubulinopathies, as some of you may be knowing, are associated with like dysmorphic basal ganglia, associated with cortical malformations. But in this case, it is not associated with cortical malformations, rather it is associated with hypomyelination with atrophy of the basal ganglia and cerebellum. Apart from that, there are certain other mutations also, for example, UFM1 mutations in which this basal ganglia atrophy may not be as prominent as is seen with TUP4A gene mutations. So these patients, because of the basal ganglia predominant involvement, there is lot of dystonias, extrapyramidal symptoms. And what do we see is basal ganglia atrophy, disappearing basal ganglia, and there may be associated lobus pallidus hypointensity as well, in addition to cerebellar atrophy. So this is another case taken from literature. In this, we see apart from diffuse mildly hyperintense signal, we see very hypointense signal of the basal ganglia of the globus pallidus. On SWI, we are seeing that there is pairing of the medullary lamina of the globus pallidus. And in addition, what provides the clue? Very good. So it is a case of leukocytosis. So what provides the clue is there is presence of certain skeletal abnormalities. So there are skeletal dysostosis, and this is a case of leukocytosis in which we see a pattern which may not be seen in all cases, but when we see it can provide a clue. So in this globus pallidus, hypointensity will be there, but there will be alternating hyperintensities within the globus pallidi. So this is again a storage disorder. So there will be associated hepatosplenomegaly, cardiomegaly, but these patients also have skeletal abnormalities as well as can have skin abnormalities like angiokeratoma diffusum corporis. And on MR, apart from diffuse hypomyelination, we see there is this alternating hyperintense signal in the globus pallidus, and there can be associated skeletal and skin abnormalities, which provides the clue. So till now we have discussed the other pattern, which was hypomyelination with involvement of the basal ganglia. Now we saw many of the cases already in which there was presence of T2 hypointense thalami. So we saw in POLAX-related leukodystrophy, there may be hypointense signal of the ventrolateral thalami. Apart from that, storage disorders like leukocytosis we saw, GM2 gangliosidosis we saw, and now we'll see another case of neuronal ceroid lipofuscinosis. So this is a case of NCL. Actually, I wanted to ask the case, but I told the diagnosis. So in this is again a secondary hypomyelinating leukodystrophy. So these children have usually very severe symptoms. They have myoclonus, they have seizures. And what do we see on MR is there is significant atrophy of the cerebral hemispheres as well as cerebellar hemispheres, as well as the thalami may appear mildly hypointense in signal. And Apart from that, how do we see hypomyelination is we see very small periventricular white matter hyperintensity, sometimes, not always, but when present, they are actually pathologically found to be hypomyelinating. So it is a secondary hypomyelinating leukodystrophy. It is basically a neurodegenerative disorder where there is marked atrophy of the cerebral and cerebellar hemispheres, which is out of proportion to the hypomyelination seen in them. So whenever we are encountering T2 hypointense thalami, so it is just one short algorithm which may be helpful sometimes. So look at the basal ganglia. So whenever there is presence of hyperintense basal ganglia and we see preserved corpus callosum, the diagnosis can be GM1, GM2 gangliosidosis, of course with certain clinical features like cherry red macula, hepatosplenomegaly, coarse faces. If no, then look at globus pallidus. If it is T2 hypointense globus pallidus, and there is presence of alternating hyperintensities, it can be fucosidosis. Again, we have to look at clinical clues. If it is not there, it may be just a case of polar related leukodystrophy, and then we look at the white matter. There can be selective sparing of the white matter. And apart from that, this hypointense globus pallidus may or may not be present, but if there is involvement of the like there is significant atrophy of the basal ganglia, it may be a case of HABC. So whenever there is T2 hypointense thalami, in case of hypomyelinating leukodystrophy, try to look at the basal ganglia, and depending upon whether it is hyperintense, whether there is GP hypointensity, or whether there is significant atrophy of the basal ganglia, we can provide a clue towards the diagnosis. Then we have, as we already saw many cases like HABC, polar-related leukodystrophy. We can have certain other disorders as well, where cerebellar atrophy is a predominant feature along with hypomyelination. One of them is 18q deletion syndrome. So in this, we see mild hypomyelination, but we see multi-organ anomalies, and we can also see inner anomalies in these patients. And then there's a very rare disorder which is known as ODD, which is actually oculodentodigital dysplasias. In this, in addition to the hypomyelination, we can see certain dental abnormalities. There can be digital abnormalities and ocular abnormalities. So in these cases, clinical clues provide the diagnosis in addition to hypomyelination. And there can be certain other features like cerebellar atrophy as well as calcifications in these cases. And cerebellar atrophy again was a predominant feature in LCL, as we already saw, in Cogan syndrome, which we'll see in the subsequent slide. So whenever we are seeing cerebellar atrophy with hypomyelination, look for calcifications. If calcifications are present, there are certain differentials which we'll see in the subsequent slide. And if calcification is not present, if there is significant atrophy of the basal ganglia, it can be HABC. If calcification is not present, but there are multi-organ anomalies, there can be 18q deletion syndrome. So then we have hypomyelination with brainstem involvement, as we already discussed about PMLD, so this is diagrammatic to represent PMD, where there was sparing of the ventral brainstem except for the corticospinal tract, as compared to PMLD, where there was diffuse involvement of the both ventral and dorsal brainstem. Then there can be brainstem involvement in HEMS, as we saw that early involvement of the posterior brainstem, and apart from that, ODD can also have. And apart from that, there is one specific diagnosis as we saw in LBSL. So similar to that, we have HBSL, and in fact, the gene is also DARS gene. So in this, we have hypomyelination, and again, similar to that of LBSL, we can have spinal cord involvement. And in this, the brainstem there can be periventricular hyperintensities. Apart from that, the brainstem involvement is usually ventral in this case. So these are very rare diagnoses, just to complete the patterns, and at least you should know about them. So that is why I'm covering them. So now coming to one important pattern, that is when hypomyelination is present with calcifications. Apart from these certain clinical clues, one of the very important disorders is this. So what are your thoughts about this? We are having diffuse hypomyelination, and we are having significant atrophy of the corpus callosum as well as cerebellum, as well as we are having on SWI blooming seen symmetrically in the putamina. So what are your thoughts about this? Yes, so it is a case of Cocaine syndrome. Again, Cockayne syndrome has certain clinical features which can provide a lot of clue for the diagnosis. For example, these patients can have cutaneous photosensitivity, progeroid faces, retinal pigmentary abnormalities. These can have dental caries. But what important pattern we should remember on MRS, apart from diffuse hypomyelination, there is presence of calcifications. Now, these calcifications are usually homogeneous involving the putamen, but in severe cases, they can also involve the depth of the sulci as well. And these calcifications may not be present at the outset, especially if the child is less than 3 years of age. And on SWI, we may sometimes not see calcifications, but if MCCT brain is done in the same patient, we may see calcifications. So in such cases where we're strongly suspecting, we may need CT to confirm to provide a clue to the diagnosis. Otherwise, whenever the clinical features along with cerebellar atrophy, corpus callosal atrophy, and calcifications is present, we should provide Cockayne syndrome as one of the important differential diagnoses. So this case we also saw in the previous discussion. So this is one of the differentials of Cockayne syndrome. Here also we see significant atrophy, but what we see is, again, we see the calcifications. But here we see more of more of demyelinating leukodystrophy. There is diffuse hyperintensities. There is very significant atrophy of the brain, and there is presence of anterior temporal pole hyperintensities. So yes, vanishing white matter is one of the DDs, but we see presence of calcifications as well, and these calcifications are periventricular. So yes, very good. It is interferonopathy, that is Aicardi-Gouttiere syndrome. So apart from diffuse, here more of demyelination, we also see anterior temporal pole hyperintensities, and we see periventricular calcifications. So one of the other DDs which we discussed again in the last lecture was, here we are not showing the calcifications, but in this also calcifications can be present, and we see lot of extratemporal, like we are seeing widening of the extratemporal spaces, and we are seeing apart from that cortical malformation. So what do you think is the diagnosis in this case? In this we are not seeing hypomyelination, just for showing you a DD of Aicardi-Gouttiere I showed you. Yes, it is a case of a torch infection. And in the last lecture, someone told a DD, so I just kept that case, which may be out of context. Maybe sometimes there are associated hyperintensities which may represent hypomyelination, but it is out of context. I'm just showing this because last time when I kept torch, so some people told that diagnosis. In this, apart from the widened extra-axial spaces, we are seeing subdural collections, and we are seeing some prominent vessels. Yes, very good. So it is a case of Menkes disease. So I just kept it because last time someone told this as Menkes disease. I wanted to show that there are prominent vessels in addition to the subdural collections present in the Menkes disease. These are very small children and have a poor prognosis. And here in this patient, there were dry skin and hair abnormalities, which are kinky hair, which are typically seen with Menkes disease. So just on the lines of Menkes disease, this is a very rare hypomyelinating leukodystrophy. It was in fact reported from our institute, where we are seeing, apart from the diffuse white matter hyperintensities, which in literature have shown to be hypomyelination, have been discussed as hypomyelination, there are prominent veins in this disease as as there are prominent Burmeian bones. So this is a case of DeBarcy syndrome, which is cutis laxa autosomal recessive type 3A disorder. So this is a very rare disorder, but just to tell you that even hypomyelination can be seen in such rare disorders, and these prominent veins also make it one of the differentials of Menkes disease. But and even these patients can have hair abnormalities. So we have covered various hypomyelinating leukodystrophies. I know it was overwhelming, but at least some patterns we should remember. And this is one algorithmic approach, which again is very complex, but actually if you keep it while reporting, it may be helpful, as we have seen, we have used this algorithm and we have been able to give some of the specific differential diagnosis. So as again, first of all, our first approach is whether there is presence of myelin deficiency on MR or not, and whether it is delayed myelination or hypomyelination. So once we have confirmed that it is hypomyelination, we can just begin with small involvement, that whether it is just selective involvement of certain early myelinating structures, then it can be HEMS. If no, then it is diffuse hypomyelination. But diffuse hypomyelination with predominant periventricular hyperintensities, if only periventricular hyperintensities are present and there is predominant cerebral and cerebellar atrophy, then it can be MCL. And if periventricular hyperintensities are present in addition to diffuse hypomyelination with congenital cataracts and peripheral neuropathy, it can be hypomyelination with congenital cataracts. Now, if they are not there, then we again move to other patterns of diffuse hypomyelination. If there is selective sparing of the white matter, these are pole 3 related hypomyelinating leukodystrophies. If no, then if we should look at whether there is hypointense thalami. If hypotense thalami is present, then again that algorithm look at the basal ganglia, and depending upon different involvement, different differentials can be put. And if again no, then look at the cerebellum. Then as we saw as we discussed previously, in case of cerebellar atrophy, look for presence of calcifications, and along with the atrophy or presence of calcifications or not, or presence of any certain specific clinical features, we can reach to a diagnosis. If nothing of these is present, look for any spinal cord involvement. It may be HPSL. If still it is not present, look for NA-like peak. It can be Salas disease. If no, then there can be certain clinical clues, for example, Hirschsprung disease or inner ear anomalies, which can be SOX10 associated PCWH. And then if no, then look for, in the end, look for brainstem involvement. If only the ventral dorsal brainstem is involved and ventral brainstem is not involved, except for the corticospinal tract, then it is PMD. And if only ventral brainstem is also involved in addition to the posterior brainstem, then it is PMLD. So this is a very complex algorithm, but while you are reporting, you can keep this algorithm with you and try to fit in each so that you can reach to a diagnosis. Let's answer what was the case of hydrocephalus. That was Aicardi-Gouttiere syndrome. I think you're talking about this case. So this was Aicardi-Gouttiere. This is the case of Torch, and this is a case of Menkes disease. So we have discussed about hypomyelinating leukodystrophies, and we discussed about demyelinating leukodystrophies in the last lecture. So MR plays a very important role in evaluation of leukodystrophies, and a unified approach, including both clinical clues and MR features, can help us in improved understanding of these important disorders. There is a definite overlap present, so whenever a case comes first to us, we'll definitely not give one diagnosis. But if there are certain specific features, for example, 4H syndrome, along with hypomyelination, and the patient has variants of uncertain significance or negative genetics, then we can tell that this is a very specific diagnosis and we can provide a clue towards the diagnosis. Then there are a lot of emerging therapies, especially for PMD and certain other disorders as well. So in such situations, advanced MR techniques hold promise that they can help in quantification of the myelin, amount of myelin, and can guide about the prognosis of how the treatment is going. So before ending, I know it was a very difficult cases, and we may not encounter them very commonly, but I want you to take at least some patterns from this lecture. So we'll again have a very quick revision of the cases which we already saw, and I hope that you all will answer. So what is this diagnosis? We see diffuse hypomyelination with involvement of the dorsal brainstem and sparing of the ventral brainstem except for the corticospinal tract. So the diagnosis is, yes, so it is PMD, very good. So we see the involvement of the brainstem except for the ventral brainstem, and only in which the corticospinal tract is involved. Then we have the other case where we have diffuse hypomyelination, involvement of both ventral and dorsal brainstem. So this is PMLD. Very good. So now you are answering very quickly. So this is a case of PMLD. So yes. So this is a case which you should always remember. There is diffuse hypomyelination, but there is sparing of certain white matter structures, the optic radiations. Yes, 4H syndrome is a syndrome associated with it, but it is a pole arch-related leukodystrophy. Actually, my question was what will be the clinical features, a specific clinical feature which can be seen with it, and you have already answered. It is 4H syndrome. Then this is a pattern in which only certain structures are involved, like there is no diffuse hypomyelination, there is trilaminar pattern. This is not a Salas disease, but here only, yes, very good. Here only the early myelinating structures are involved. So this is EMS, that is hypomyelination of early myelinating structures. Remember the trilaminar appearance of the posterior limb of internal capsule in this case. Then this is a case where we have cataracts, we have diffuse hypomyelination, and more conspicuous hyperintensities in periventricular white matter. So this is a case of, as the name suggests, yes, hypomyelination with congenital cataract. Then this is a case which you should remember, this pattern you should remember. So it is a secondary hypomyelinating leukodystrophy where we have diffuse hypomyelination but hyperintense basal ganglia and preserved corpus callosum. So this is a case of, yes, very good. So infantile onset GM1, GM2 gangliosidosis. So this is another case where there is diffuse hypomyelination with atrophy of basal ganglia and cerebellum. So it is, yes, very good. So it is HABC. So the other pattern where we have hypointense basal ganglia with skeletal abnormalities, along with that we can have a lot of skin abnormalities as well. So this is a case of, yes, fucosidosis. And then we have Cockayne syndrome where we have diffuse hypomyelination along with calcifications. And so this was the last case which I wanted to show you. This is Cockayne syndrome, and we have differences like Aicardi-Goutier's and Torch infections. So these were the patterns, and of all these patterns, please remember PMD, PMLD, Polar 3, and along with that, infantile onset GM1, GM2 gangliosidosis. So thank you very much. So these are my references, and I thank Ref for giving me this opportunity. Ref is wonderful, and right from my PG days, I have been using it as a very useful source for learning, and I know you all are using it too, and it is so useful for all of you as well as all of us. And I want to thank my mentors, Dr. Bijoy Thomas sir, Dr. Soumya ma'am, and Dr. Keshav sir for helping me with this presentation, as well as my mentor from AIIMS Jodhpur, Dr. Sarvesh sir, and my friends from my department who have helped me with this as well as the previous presentation. And thank you very much. So the references, like this is one of our article. Then this was the adult leukodystrophies from radiographics. And this is another very important article, solving the hypomyelination conundrum. So this is again a very prominent article, and you can read this article as well. So these are the references, and thank you very much for your very nice participation. Thank you.
Thank you, Dr. Smiley. Thank you. I think you have simplified it well, and all the thank you messages are just trying to show that only. So thank you so much for covering such a difficult topic. It literally scares all of us out. So you have tried to make it as simple as possible. The algorithm approach and everything was really helpful. So we'll have you back with some other topic. Thank you so much for covering this difficult topic.
Thank you so much, ma'am. Thank you for giving me this opportunity. Thank you, ma'am.
Well deserved.
Thank you everyone for your very nice participation.